Sir, our diagnosis is provisional diagnosis is
Next slide.
malunited Colles fracture.
Malunited Colles fracture. Okay. Why do you say it's malunited Colles fracture?
So the patient first presents with the dinner fork deformity, sir. Came with the complaints of dinner.
You never knew about the when the patient presented to you. Now why do you say it's a malunited Colles fracture? That's the question.
First is the age, sir.
Age, okay.
Age. Since she is an elderly patient, it could be osteoporotic fracture, and the fracture is not united. Now
Not united. See, that was what sir was saying. You should not use any should make any basic mistakes. So it's a metaphyseal fracture which will unite. Not united is something you are going different plane altogether. Because if you bring in that question, you will have to distinguish between malunion and non. ഇതെല്ലാം ചോദിക്കും. തിരിഞ്ഞാ? Okay.
It is malunited, sir. So the patient now presents with the deformity.
What deformity?
Dinner fork deformity, sir. And
what are the functional disabilities, functional problems?
So the dorsiflexion and the palmar flexion of the wrist is restricted.
Which is more restricted?
Dorsiflexion, palmar flexion is more.
Palmar flexion is more restricted when compared
restricted.
to. So what about the position of the ulnar styloid, radial styloid?
Same level, sir. Ulnar and radial.
Usually, the distal radial styloid will be at a lower level when compared to the ulnar styloid. What happens in Colles fracture is only proximal migration. Now, what are her complaints?
The patient complains of deformity.
Deformity. Okay. Now, what will you do for her?
If that deformity is restricting her day-to-day activities, I will be going for osteotomy.
No. What will you do to her means? I would like to know what her current status is. It's non-union, malunion, or something else. Was it a compound fracture which led to non-union, or something else? So you will always ask for investigation. I'll ask for an X-ray. Never go for anything. Surgery, orthopedics, gynec, anything. Never say the management. Management starts with investigations. Then only go for your osteotomy. If you straight away say osteotomy, go and come next time.
Sir, first I will do the basic investigation.
What basic investigation do you want here?
X-ray, sir.
X-ray, okay. X-ray. Okay. These are her X-rays. See, this is the X-ray. What do you find here?
Sir, it's a plain X-ray of
a skeletally mature patient.
Plain X-ray of a skeletally mature patient of wrist joint showing postero-anterior view.
AP and lateral view, say like that.
AP and lateral view, sir.
Showing what?
It is showing some dorsal displacement at the lateral view.
Okay, some dorsal displacement. Okay, we agree. What do you see? You have to make a comment about the bone density here.
Sir, there is some some thickening of the bone.
See, osteoporosis is one condition I told you where the bone mineral density is reduced for age and sex matched controls, characterized by three things. One is increased fragility of the bone. Second one is microarchitectural deterioration. Third one is making them susceptible for micro fractures. This is a macro fracture. And if you look carefully, what you find here, there is density, diffuse osteopenia in the carpal bones and the metacarpal bones. What is that? Is it osteoporosis or something else? Can you appreciate the density change in the metaphysis of the radius and density change in the carpal bone? What is that? Osteopenia. Why there is osteopenia? Why there is selective osteopenia in the carpal bones? Disuse atrophy. What happens? There is in the normal bone there is a hemostasis between bone formation and bone resorption. It will be this process will go on from your birth to your death. After the age of 30, there is constant bone loss. Now after the postmenopausal, again accelerated bone loss, senility, accelerated bone loss. Added on to that, post immobilization stiffness. That's the cause of osteopenia. Now what will you do for this patient? We'll go fast.
Sir, I will correct that.
See, you have to assess the functional disability of the patient. Is the patient able to carry out her activities of daily living? Right-handed patient, left-handed patient. Right hand dominant patient. What are her functional disabilities? I told you a malunion is treated only when it is functionally compromising or when it is cosmetically deforming. So what will you do?
Sir, I will ask whether.
She is a 75-year-old female. I talked with the patient, talked to the bystanders, then
So, if it is functionally compromising her day-to-day activities, I will proceed
With what?
With, osteotomy.
osteotomy and
Osteotomy and
before that, what's the most important thing you will do?
uh,
What's the end
reduce
organ? End organ is the hand.
hand.
Hand function. What are the functions of the hand? What are three functions of the hand? Pinch, grasp, and hook. You give a sufficient range of physiotherapy. I told you about the switchboard and the bulb. Once the bulb is not working, there is no point in repairing the transformer, switchboard, or anything. So you give a course of physiotherapy to see the range of movement. Then, if the patient is functionally demanding only, you will go for a surgery. So you will be asked everything about Colles fracture. You will be asked everything about osteoporosis and all those things. Sir, any questions? See, that's how you'll be asked questions. You can go from here to osteoporosis, the reflex sympathetic dystrophy, malunion, non-union, cause of non-union, malunion, all those things which I told you may be asked here. Okay, good. Next case.
Now I'd like to call upon Renuka Devi and Krishna for presenting on wrist drop.
No. This is the scenario. Come and present. See, 35-year-old male who is an alcoholic. 35-year-old male who is an alcoholic had a heavy bout of binge drinking, and he's just slept like that. Then next day morning he is unable to extend his Saturday. No, let them present. Saturday night palsy. What is Saturday night palsy?
The last day the person will drink and they'll sit on the chair with the arms and the arms.
What is Saturday night palsy? Saturday night palsy is a
higher radial nerve palsy.
Higher radial nerve palsy.
The axilla. Due to neuropraxia, sir.
Don't. You should be smart. Don't be over smart. You know the answer. You are trying to be over smart. Since you told neuropraxia, you could have made me ask that question. I just asked you what is the problem. You say it's Saturday night palsy, high radial nerve palsy. What type of nerve injury? You can be smart, but not over. Sir, corrected. You can be smart, but not over smart. So that's a neuropraxia. Then you will be asked about whatever I told you. What's neuropraxia? What are different types of nerve injuries? Now how will you manage him?
Sir, we can wait, sir. Cock-up splints, sir. We can go.
Oh, what's a cock-up splint? What does it do?
It promotes extension of the wrist joint, sir.
Is this a static splint or a dynamic splint?
So we are having two types. Cock-up splint is a static splint, sir.
See, we do not want the wrist to. Then the next question: what is the functional position of the wrist? What's the functional position of the wrist? Anybody? Please raise your hand and show me. This is the functional position of the wrist. Keep it like this. It is extension of the MCP joint, flexion of the MCP joint, and flexion of the IP. This is the functional position. We do not want the wrist to be like this. So if it is kept like this, it will be like this. So we would like to prevent the contractures. For that you give a cock-up splint. Okay. Now what will you do? It's not improving. The patient says, I was assaulted. This injury changed it into, patient had an injury 6 months back. I had a fracture of the humerus, which was treated, and now I am having a wrist drop.
So we'll wait for critical time period for the upper limb is 9 months.
We have waited for 9 months. Now what will you do?
So we'll go for tendon grafting.
No, you go for?
Nerve
No, you have to investigate. What investigate?
So first we have to take an X-ray to find out there's underlying fracture. Then we can go for MRI to see a soft tissue damage in nerve.
Patient is too poor for all those
Nerve
investigations.
conduction
Simple investigations. EMG and nerve conduction velocity to know the continuity of the nerve. Then you can obviously take an MRI, which is not much use. Then you plan whatever I told you, end-to-end suturing or whatever. It's not working. Then what will you do? Then you think about tendon transfer. So you should know everything about the muscles innervated by the radial nerve, high radial nerve palsy, low radial nerve palsy, and the presence of other muscles innervated by the median nerve and ulnar nerve for transfer. Now you will be asked, how will you classify, how will you grade the muscle power? Whose classification? MRC. What is grade 0? Grade 1? Grade 2? 3. Good. See, these are the questions which you should be, will be commonly asked. So you will be given a pass mark. So you can be smart but not over smart. I didn't ask you about neuropraxia. So we'll ask about so many things. What's the normal velocity, all those things. If you say neuropraxia without me asking you the question, I'll ask you what is the normal velocity of the nerve, what is the latency, what are so many evoked potential, all those questions will come. So don't make me ask such questions, okay? Be careful. Good. Sir. Okay, they can't hear. The question is, how will you know it's a high radial nerve palsy or a low radial nerve palsy?
Radial nerve starts from the axilla. Okay? It travels in the arm, forearm, up to the wrist level. How will you locate the lesion? How will you locate the lesion?
One clinical examination.
Again, you are dragging me to the basics. What are the muscles supplied by the radial nerve? Muscles supplied in the arm, muscles supplied in the forearm. See, you are dragging to me to
ask unnecessary questions, unpleasant questions to you.
Right?
Which you don't know because you are not strong in your anatomy. You got the point where you made the mistake. So if you don't understand the question, sir, I didn't understand the question, please repeat the question. That's okay. Fair with us.
How will you locate? This is important. Injuries in the arm level or injuries in the
What deformity?
what deformity?
Now that question comes. Again the question comes. Now, simple. What we are expecting was just one simple examination. Since you have brought deformity, now we will go to cubitus varus. Cubitus varus. What
are the muscles you will check? Radial nerve. From the arm. If I ask one question, go in order.
Listen to the question. There is a clue for your answer in the question. Sir was asking proximal, distal. In other words, which higher radial nerve palsy or low, where does the radial nerve divide into two parts, superficial and deep?
Which muscle you will check? By deformity itself, you can say that higher level or lower. Is it not? Is it correct or not? What are the deformities? What do you see? Wrist drop, finger drop, thumb drop. Only finger and thumb. What is the level? That's why I am asking, how will you check? Which muscle you will check?
No more clues will be given. No more clues will be.
No more clues.
No more clues.
See, 3 drops. Wrist drop. Again and again and again I am telling. Never ever do a blunder in the basics. What is the function of, what is the muscle for wrist drop? wrist dorsiflexion?
Extensor? Extensor, what extensor? How many extensors are there?
No anatomy, no orthopedics. I am telling repeatedly. No anatomy, no orthopedics. What is the muscle for wrist dorsiflexion?
Wrist extension. What are the muscles? Basically, there are 2 groups of muscles. Ulnar deviation and radial deviation. What? Wrist.
Ulnaris. Then, in which area ECRL and ECRB gets supply from radial nerve?
Is it before the bifurcation or is it above the bifurcation? That's it. Above the bifurcation.
See, my professor used to say that frequently. Orthopedics is 60% common sense, 20% hard work. Only 20% you need IQ. Orthopedics is 60% common sense. Right? If ECRL and ECRB is intact, what is the mean? The injury is after the division. What is the division? What are the 2 branches? Posterior intraosseous nerve. So only if the patient is having only finger and thumb drop, what is that level? It's a calculation. 2 plus 2 is 4. So be strong in the basics.
See, these questions will be asked. So you must know simple anatomy. Where does the radial nerve arise? Which root, which cord, all those things, course of the radial nerve. You are expected to know all these things.
If you have a wrist drop, thumb drop, finger drop, it's a higher level. Only thumb and finger.
Distal.
Distal. What is the distal? Posterior intraosseous. That's all. Will you go for next case?
Yeah, next question. So you should know about tendon transfer. What are the principles of tendon transfer? That's a slightly higher level. Shear tendon transfer, that's enough. So that's PG level. Okay, you should say tendon transfer. It's after 9 months. Sara, he was repeat. No. The examination you don't get this much time to present. You forget about what you have prepared. Now you be ready for the answers. Now, this patient has sustained a road traffic accident. He underwent multiple surgeries, and now the patient is presenting with difficulty in walking, with a discharging sinus and some discoloration of the leg and some mobility at the fracture site. Painful mobility at the fracture site. That's the history. So 40-year-old man, road traffic accident, compound fracture, treated by some surgeries, multiple surgeries. Now after 2 years, present with a discharging sinus and some mobility at the fracture site.
It's mostly, my provisional diagnosis will be chronic osteomyelitis with
I heard something else also. Some mobility. Did I say mobility? Did I use the word mobility? 2 or 3 surgeries, 2 surgeries.
So the fracture, implant infection.
Implant exit, right? Good.
Implant exit will be there.
What is the sequelae of implant exit and abnormal mobility?
Chronic osteomyelitis infection.
You listen to the question. Sir was asking about mobility at the fracture site.
He underwent 2 surgeries. Okay. Implant exit. Okay. Abnormal mobility. So what is the sequelae?
Infection is present because there is a discharging sinus. Abnormal mobility is present. So whenever there is a fracture, there will be a painful abnormal mobility. Once the fracture is united, there will not be any abnormal mobility. There will not be any abnormal mobility. There will be only transmitted mobility present if the fracture is united. Now the scenario is the fracture is not united. Is it an ununited fracture or non-union? If there is pain at the site of the fracture site, it is an ununited fracture. Non-union, it will be painless abnormal mobility. Here there is some pain. That means, what do you mean by, what do you infer from that?
So it's mainly due to non-union of the fracture.
You are again.
So now
Didn't you listen to what I said? Non-union is a clinical condition where there is painless abnormal mobility at the fracture site and absence of transmission. Here there is some pain.
Pain in
Young patient,
united.
ununited fracture.
Ununited fracture.
There is body is trying to unite. Now the present situation is a discharging sinus with 2 scenarios. One is an infected fracture. Second one is a non-union. How will you proceed?
So first you have to order an investigation.
What investigation do you want?
First you have to prefer sinograms.
What sinogram?
Servicing that eye gastrograph. X-rays.
I told you, whenever you are suspecting a non-union or non-union, you think about the causes of, I told you, the causes of non-union. What are the causes of non-union? Systemic factors, local factors. You order all the blood investigations which might have led to this immunocompromised patient. Then you ask for a total count, differential count, and ESR, C-reactive protein. Then you ask for what? Your X-ray. And then you go for the other investigations. X-ray under, sir. So your line of investigation will be to rule out the causes which are led to non-union, like a systemic cause or a local cause. Systemic cause, old age, debility, infection, renal disease, liver disease, all those things has to be ruled out. Then you rule out acute causes which we are going for the X-ray.
You want to know the organism is in the blood or any other?
Sinus.
Okay,
culture,
so you want to
culture
know the organisms in the blood or any other
sinus.
thing?
On the discharge.
What do you want to see? What investigation you want?
Culture of sinus discharge.
So you don't like
Sir,
to see what is inside.
Mike. They are not listening.
So you no need to see what is inside.
You have to see inside.
Huh? So you want to see the organisms in the blood or eye or ear or liver?
Blood.
Huh?
Blood and sinus.
You are a hematologist? You are appearing for hematology exam?
Most.
Then what is your diagnosis?
Osteomyelitis.
Osteomyelitis.
Chronic osteomyelitis.
So you see the blood culture and saying that is osteomyelitis?
Most.
Then what do you want?
Pus culture.
Pus culture. Then see if pus culture positive comes for staph aureus, then you say osteomyelitis?
Most.
Then what else you want?
Sinogram.
You don't like to take X-ray?
Take X-rays.
Then?
Already mentioned.
He mentioned the X-rays?
X-rays.
Yes, he said X-ray.
Yes.
Read the X-ray, please.
Sir, it's X-ray of knee joint with the
Knee joint. Where is the knee joint? Sir, knee joint. Sir is here. Sir is asking where is the knee
Again, you
joint?
are giving a knife to me.
Where is the knee
The
joint?
knee joint?
No, sir. No, sir.
And then what is this bone?
Take your own sweet time. You have been given this X-ray. നേരത്തെ കൊടുത്തല്ലേ? You have-
Good. What is this X-ray?
X-ray showing tibia and
What is this X-ray?
plain X-ray, sir.
What are the bones you are seeing?
Tibia and fibula
Then where is this knee joint?
showing ankle joint,
Part of the angle, okay.
part of ankle joint.
So showing what?
Fracture at the tibia.
What is striking?
What is striking?
What is striking?
So there is a lesion in the
What lesion? Constructive lesion or
dark
destructive lesion?
Sir,
Constructive lesion or destructive lesion?
destructive lesion.
You say that is destruction? I am giving clue. Don't copy
He is
from
trying
me.
to he is trying to help you. Internal examiner.
What do you see, man?
So there is some lesion in the
What lesion? Dense lesion or something else?
See, whenever you are seeing a lesion in the bone, as I told you, imagine what's the lesion trying to do to the bone, what's the bone trying to do to the lesion. Here is it a lytic lesion or a sclerotic lesion?
Simple.
Or-
It's a lytic lesion.
lytic lesion of the bone.
That word conveys everything.
lytic lesion with what? Is it
What?
well
Then
contained?
you have to describe the lytic lesion. As Sir says, what the lesion does to the bone, what the bone does to the lesion. Describe.
So there is a sinus.
Sinus.
You are
What,
saying
now
you are
again
saying
you are
sinus
digging your grave. What's the sinus?
A sinus is a
Sinus is a
Blind tract.
sinus is a
blind tract.
blind tract. That's a clinical
Leading to
diagnosis. How do you find the sinus tract here?
Show me the sinus in the X-ray.
തീർന്നില്ലേ? That question will
Show me the sinus in the X-ray.
see, these are the common mistakes which you make. Sinus is a clinical diagnosis. Here you cannot say sinus. You can find a radiolucent
Sure, okay.
area
Lytic-
surrounded by a sclerotic margin, and what do you find inside the lytic lesion?
Lytic lesion where? Proximal, distal or away from the bone, outside the bone?
Which part of the epiphysis, metaphysis, diaphysis?
It's a tibia or fibula?
Tibia, sir.
Tibia, okay. Then, which part?
Diaphysis.
Diaphysis.
What do you find inside the cavity?
Dead tissue.
Huh?
Dead bone.
And again, a radio dense lesion is found inside the cavity. What could it be?
Sequestrum.
Sequestrum. What's a sequestrum?
Sequestrum is a devitalized dead cortical bone.
Dead bone.
Dead bone.
Don't use
Around
any.
the new.
Say dead
Around
bone.
the normal.
Dead bone found in infection is called sequestrum. Okay. What has happened to the fibula?
So there is a fracture.
No, what has happened? The fibular fracture has united.
United
So I told you one of the causes of non-union will be an intact fellow bone. Here there is intact fellow bone, infection, but there is no mobility. There was no mobility. No mobility. So how will you proceed? Now you have a situation wherein you have an infection and an ununited bone. How will you get rid of the infection?
So you know antibiotics.
How you are given antibiotic for 4 to 6. How long will you give antibiotics? After culture and sensitivity, you are given antibiotics. How long will you
4
give?
weeks.
4 to 6 weeks.
4 to
And
6
even then the X-ray is like this only.
Continuously discharging. 4 to 6 weeks antibiotic completed.
Then surgical management.
What surgical management?
First you have to remove the
Herniorrhaphy?
no sir.
Ah.
Sequestectomy along with saucerization of the bone.
Debridement including
Surgical debridement including sequestectomy along with saucerization. You have to fill the defect with the bone cement.
Bone cement. No. Not bone cement. You could have stopped at your level. Why did you dig for the bone cement and all those things? You could have stopped at saucerization. Fine.
don't act too smart.
Don't act too smart.
Too smart.
Simple answer would have been I would do a debridement, saucerization, and wait for the cavity to heal. You can make a closed cavity into an open one, and you wait for the granulation tissue to heal and remove the sequestrum, and then you can place what is the drug eluting bone cement, which will elute antibiotic locally, and then once for the fracture is healed, you can do a definitive fixation on if necessary. So here it's a case of osteomyelitis. Questions will be, what is osteomyelitis?
Infection of bone and bone marrow.
Infection of bone and bone forming elements. Now your questions will be, what are the complications of osteomyelitis? What are different types of osteomyelitis?
Acute, chronic, subacute.
Acute, chronic,
Then
subacute.
Based on etiology,
And
biology.
she is trying to See, I didn't ask you that question.
See, whenever examiner asks question, just listen the question.
Don't try to give all your knowledge. You can, if you get a chance, you can say. You are trying to be over smart. Got the point. You don't make this mistake in the examination. So, and we are in the acute, chronic and subacute. Okay. Now what will you do? What are the complications of acute osteomyelitis?
Pathological fractures.
Acute turning chronic. Then pathological fractures. Then
Infection spread, septicemia.
septic
arthritis.
Suppose it's occurring at the epiphyseal region, or the growth plate.
Shortening.
Yeah, you
Limb
can
shortening.
get limb length discrepancies. Pathological fractures. And then next question will be, what's a pathological fracture? Then comes osteoporosis. It can go on like that. Okay. So here we have infection and an ununited fracture. Don't forget about the status of the fracture. Primary concern is to get rid of the infection. Once the infection is controlled, then you look for the stability. Stability can be achieved by different methods, by nail, plate, whatever. Okay.
He mentioned cyanogram. When will you do cyanogram?
If there is an intact sinus.
Intact sinus. What's an intact sinus? Why do you want to add that intact word
What
there?
is intact sinus? What is extract sinus? What is the difference between the intact sinus and extract
Why did you bring in that word? See, these are the mistakes which you will also make.
Repeatedly I am telling, don't give too complicated answer. First rule. What is the first rule? What is the first rule? Don't give too complicated answer. And don't act too smart.
Because he used the word intact, we'll have think about other things also. So be simple. The presence of sinus. So you have understood your flaws.
Yes, sir.
Listen to the question carefully. The other was repeatedly trying to bring the answer of extensor carpi radialis longus. Now, which if you had listened to the question, which muscle, radial nerve, what is this? Extensors of the wrist.
Even then you didn't give answer?
Then we'll ask about the anatomy, course of the nerve, all those things. Is it clear? Yeah.
Yes, sir.
Then when will you do cyanogram?
Sinus.
How many sinus you have seen? See, digging your own grave. How many sinus you are seeing? What is the role of cyanogram?
Extent of the sinus.
You yourself committed. No?
Extent of sinus.
Anyone ask cyanogram? No, tell me. Tell me
Extent
about
of
it.
sinus. Extent of sinus. Whether
What
it
extent of
extended into the tissues. Bone.
When will you do cyanogram?
When? Since you have used the word cyanogram.
Yeah. Tell me.
What is the purpose of doing a cyanogram? What's the purpose of doing a cyanogram?
If
Your
you
depth
have
of
multiple
invasion.
sinus, you don't know which sinus. In general surgery, when will you do cyanogram? Tell me one condition. Cyanogram you will do. Tell me one condition.
There are multiple sinus.
Where you will get multiple sinus?
Water perineal region. Perineal anal region.
Tell me the commonest condition. No. Have you heard about pilonidal sinus?
Pilonidal sinus.
Then what do you mean by pilonidal sinus?
Jeep sinus in the back tuft of us.
Surgery 0, orthopedic 0. Ragging வாங்குனதுக்கா? Claps எதுக்கு ragging வாங்குனதுக்கா?
Next, I would like to call upon Ram Kumar and Soumya Narayanan.
This is probably the last case, and the examiner will be in a hurry to leave the examination hall. So I'm just trying to give the swelling of the lower end of the thigh, 15-year-old boy. You had a clinical diagnosis. But no systemic features of pain. There is a history of pain. There is no fever.
What is the diagnosis?
15-year-old boy. Yeah. I think I have told it in detail.
What is your diagnosis? See. Where is the swelling?
Distal femur.
Distal femur.
See, whenever sir was asking where is the swelling.
Right.
This obviously is the femur is obvious to all of you. The answer we are expecting is where epiphysis, metaphysis, diaphysis.
Inner aspect of right knee.
That is obvious. Which part of the bone? Epiphysis, metaphysis. After examination, inner aspect, outer aspect, we are not bothered. Which part of the bone?
What type of, what is the consistency of the swelling?
Smooth in
Smooth.
the surface is smooth.
What is the consistency of the swelling?
Sir is asking what is the consistency of the swelling. What is he having in his mind?
Now we are conducting which exam? General surgery or orthopedics?
Hard and consistent.
Which consistency will you expect?
I would like to know whether it's cartilaginous or bony or a bursa or something of soft tissue swelling. It's a firm in consistency. The bony swelling. Orthopedics we don't keep soft tissue swelling, most probably. Bony heart swelling. Yeah. Bony heart swelling where?
Probably metaphysis of
Metaphysis of?
femur, sir. Distal femur.
Metaphysis of femur. So what do you think as a differential diagnosis? Diagnosis, differential diagnosis and management.
Diagnosis of benign bone tumor, probably osteochondroma.
Osteochondroma is an incomplete answer. Osteochondroma of?
Osteochondroma of distal femur, the anterior aspect of distal femur of right leg.
The swelling is progressively increasing in size for the past 3 months.
Then must be a malignant one.
Probably that history was not given to you. Now I am giving you a history of progressively increasing pain and swelling.
Okay. If it is a soft swelling, okay, what will you look for? If it's a bony heart swelling, diagnosis is exostosis or osteochondroma. If it is soft swelling, what are the examination you will do?
Fluctuation.
What fluctuation? What structure? What is the important structure inside the medial side of the lower thigh?
Medial condyle femur.
What is there? Soft tissue. Listen to the question. Servers say what soft tissue.
Soft swelling. What is the important structure in the
Soft tissue.
Now I tell even clear. Posteromedial aspect of the lower thigh. What is the important structure in the posteromedial thigh?
Popliteal.
What poplite? Where is the popliteal fossa?
Foci.
Where is the popliteal fossa? Okay. What are the contents of the popliteal fossa? Structure. What is the important structure?
What structure is there? What structure is present on the medial aspect of the thigh, which is very important structure? Bursa, is it that important? Important. Adductor can.
Nerve, one nerve. Next. Artery. So these are all the two important structures for the viability of the limb. In the posteromedial aspect, which structure? What popliteal artery? Anteromedial aspect. So no.
Medial side.
Medial side. Which artery? What do you mean by adductor hiatus?
Adductor canal.
Which structure passes through the adductor hiatus and adductor canal? What artery? Aorta? Aorta is passing through the adductor canal? Which artery? Could it be a aneurysm of femoral artery?
Yes, sir. This is soft.
That's why I am asking. If it is a soft swelling, what examination you will do?
So basically we are in orthopedics. Let us stick on to the bone.
Okay, sir.
Bone. So bony heart swelling.
Why I am asking is distal neurovascular stimulus. Suppose if this is a bony heart swelling, what is the pressure effect?
What structures are likely to be involved?
Huh?
Which nerve?
Which nerve? Radial nerve, medial nerve? Then? Huh?
Lateral popliteal nerve on the medial side. Adductor canal.
Okay. In the distal part, Which one will you check for? In the foot. This swelling can compress which structure? Suppose if the swelling is a huge one, it could compress which structure?
Blood vessels.
What blood vessel?
Femoral artery.
Then how will you check for femoral artery compression?
Pulsations.
Huh? What pulsation?
Popliteal pulsation, peripheral.
Popliteal pulsation.
Dorsalis pedis artery pulsation.
No one will ask you like this in the exam. Okay? You call it 0? Egg shape of egg, you know? Put it and go.
Okay, now how will you proceed?
What do you want?
Investigation.
What investigation?
X-ray.
X-ray.
Why can't you say that X-ray?
X-ray, X-ray.
Next. What is it? Read this X-ray.
So plain X-ray
Okay.
of
No one will give contrast X-ray. No problem. Tell me.
of knee joint
Okay.
showing femur,
Okay.
tibia and fibula.
Okay.
The epiphyseal cord not fused, and the
What is striking?
the swelling and the
What swelling?
metaphysis. Bone is swelling, and the metaphysis of medial aspect, the medial side
Is
of
there any
distal
shape?
femur, pedunculate of shape.
That's an exophytic pedungulated mass arising from the medial aspect of the femur.
That's why I told what I told. You have to make a note to use a proper word. If you use that particular word, no more questions. Go. Now describe.
Plain X-ray showing knee joint.
Okay, plain X-ray. Come.
Don't repeat.
Don't repeat. We know it's a plain X-ray.
Exophytic pedunculated bone is outgrowth in the medial aspect of distal femur,
Arising from
metaphysis of femurs.
well-defined cap or ill-defined cap?
Well defined.
If it is ill-defined, what it means?
So
Already
malignant.
Sir has asked the question.
Malignant means ill-defined means malignant.
Malignant change.
Malignant change.
So how will you know whether that's malignant change or not? We are not sure. Is the cap visible radiologically?
No, sir.
So what will you do?
CT.
CT, cartilaginous cap which is not visible in the X-ray. Bone CT, cartilage, soft for an MRI. Yes, for an MRI. What do you look for in the MRI? You look for the height of the cartilaginous cap. It is more than 1.5 centimeters. It is suggestive of malignant transformation. Then in that case, you will have to do a biopsy to know whether there is what are the malignant changes which can occur in osteochondroma.
Which carcinoma arises from exostosis?
Which the correct answer. Which malignancy arises? Which malignancy arises from osteochondroma?
Osteochondroma.
Yeah, chondrosarcoma. This is a simple answer. Chondrosarcoma. So what's the treatment? What are the questions I told you? What are the causes of pain? When will you excise an osteochondroma? How will you excise the osteochondroma? These are the questions which will be asked. And you look for any other swelling anywhere in the body because hereditary multiple exostosis, short stature, all those things are associated with malignant transformation. So treatment will be, what's the treatment? What are the causes of pain? First thing is fracture of the pedicule, second one is a malignant transformation, third is a bursa, fourth is nerve irritation. Here it may be a malignant transformation or a fracture of the small stalk of the pedicule. The patient might have sustained a small fall. And the fracture might be the cause of the pain. What's the treatment? The extra periosteal excision of the tumor is the treatment. And biopsy.
Biopsy.
Okay.